Hello, and welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the JOP. Every year since 2014, ASCO has published an annual report titled The State of Cancer Care in America, with the goal of increasing awareness among policymakers and the larger cancer community about opportunities and challenges in the delivery of cancer care in the United States. The 2017 version was just published in March, providing a comprehensive and up-to-date look at demographic, economic, and oncology practice trends impacting cancer care in the United States. Joining me today to talk about the 2017 report is Dr. Robin Zahn, an oncologist and clinical investigator at Michiana Hematology Oncology in Indiana. Dr. Zahn has held many leadership roles at ASCO, including serving on the board of directors from 2010 to 2013, and she has chaired multiple committees, currently as the incoming chair for the Government Relations Committee and current co-chair of the Clinical Pathways Task Force. Dr. Zahn is also a fellow of the American Society of Clinical Oncology. Dr. Zahn, thanks so much for joining me today.
Thank you, Dr. Pinnell, for inviting me to speak with you today regarding this report.
So, can you just tell me a little bit about the State of Cancer Care reports? What's the purpose of this and what does it cover?
So you had mentioned in the introduction the purpose, and I just want to reiterate the importance of this report in the sense that it's meant to increase policymakers and the larger cancer community's awareness about both improvements, but also current challenges in the delivery of high-quality cancer care. But along with sharing that information, the report also offers recommendations on potential improvements. As you mentioned, this is an annual publication, and in fact, this was the fourth report that has been published just this recent March. That said, this year's analysis of the state of cancer care reveals actually very many promising trends. There are improvements in the development of immunotherapy and precision medicine that many of us in clinical practice get to experience now on a daily basis, as well as the importance of the emergence of big data to advance our understanding of quality and outcomes to not only answer pressing research questions, but also to fill the real-world evidence gap with regards to how our patients do who are not part of clinical trials. And in addition, this report shows progress in how the delivery of care to enhance the quality and value of cancer care is being transformed. From the standpoint of why this is important to the oncology community at large, it's really meant to help our members not only to understand the overall landscape of oncology care, but we want to hear from them. So with this report, ASCO wants to get validation from the members as to whether or not they agree or disagree with what the conclusions of the report are. But in addition, the report is also meant to help physicians and providers be able to prepare for the future so they can continue to deliver the improvements to our patients while addressing the challenges that we do approach on a daily basis. And finally, there's also the goal of being able to assist our providers with this information so they can use it locally or even federally to try to advance policy.
So the report is enormous, so we're certainly never going to be able to cover everything in the time on this podcast. But in general, it seems to be broken down into four major sections. So maybe we can go through them one at a time. The first section highlights the balance between the progress that's being made in cancer treatment and the challenges to delivering affordable, high-quality care. So what does ASCO see as the major highlights from 2016?
Well, there are many highlights, as you mentioned, but the ones that I'd like to focus on for today's podcast is the progress that we've made in cancer care is exemplified, for example, by the U.S. Food and Drug Administration, or the FDA, having added 5 new drugs and biologic therapies to its list of more than 200 approved anti-cancer agents, as well as the expanded use for 13 marked cancer therapies, and also approved several diagnostic tests that help leverage the cutting-edge scientific advances, including liquid biopsy and next-generation sequencing. And in addition, the mortality rates and overall cancer incidence were lower in 2016 than in previous decades. So this is certainly a signal that what we've done in the past and what we are currently doing and what we'll do in the future will continue, we hope, to have those types of results. Also very important with regards to the highlights is the fact that there has now been a galvanized research community. As many folks in the audience will recall, the Cancer Moonshot Initiative, started by President Obama and Vice President Biden, helped garner momentum in the cancer care and research communities to accelerate the progress in treating and preventing cancer. So through the Cancer Moonshot Initiative, President Obama and Vice President Biden were able to garner momentum in cancer care and in the research communities to accelerate progress in treating and preventing cancer. In addition, the 21st Century Cures Act, which was signed into law in the late 2016, also established long-term funding streams for the Moonshot Initiative, which was not meant to supplant the NIH, but to supplement research funding. And in addition, there are provisions included in that act that help to try to address the issues of interoperability and information blocking, which we'll talk about later. But interestingly, along with all of the wonderful trends, including the fact that our Americans are growing older and they're living longer, there are challenges. And specifically, those challenges include the fact that along with the growing numbers of folks who are now hitting the age in which we start to see an increase in incidence of cancer, is that there's been a tremendous influx of the numbers of cancer patients into the practices. In addition to that, there are barriers to achieving accessible and affordable care. Although the ACA was able to help 20 million Americans gain insurance and reduce the number of uninsured to 27 million, unfortunately, even for the insured individuals, cancer care is often not affordable. In fact, recent findings suggested that approximately 1/3 of working-age cancer survivors incurred debt as a result of their treatment. And similarly, for Medicare beneficiaries, there's some information that suggests that they spend an average of more than $8,000 in annual out-of-pocket expenses after a cancer diagnosis, which amounts to about a quarter of their income. So although there's this wonderful progress that's been made, we do have these challenges that we are dealing with on a daily basis.
Oh, absolutely. I think this is a really nice summary of everything that the big issues that have been going on, certainly in the last year, with the affordability and coverage for care. So what is ASCO doing and what recommendations are they making to try to address some of these challenges?
Well, certainly, as everybody is aware, there's been a lot of discussion with the incoming administration about repealing the ACA or perhaps altering it. So ASCO remains bipartisan, but we remain partisan when it comes to our patients. So ASCO is advocating for policies that provide adequate coverage for cancer-related services, especially for those who are vulnerable and underserved. In addition, we believe that all patients with cancer should have health insurance that guarantees access to high-quality cancer care delivered by a cancer specialist in a very timely manner. In addition, ASCO applauds the fact that the 21st Century Cures Act was signed into law. But moving forward, we believe it's important that the federal government continue to provide adequate funding and infrastructure support for cancer research, in addition to what's being supplied by Moonshot. There's, of course, concerns, most recently with the proposed budget from the administration, that the cuts that were proposed could, in fact, stifle ongoing and promising research. In addition, the FDA certainly plays a very key role, as we well know, in moving innovative cancer treatments from the development phase to regular use in my daily practice and in your daily practice. And that's certainly demonstrated by the new therapeutic as well as the diagnostic approvals in 2016. So ASCO is recommending that Congress ensure that FDA has adequate resources and authority to review and approve therapies efficiently and effectively, while also ensuring patient safety and the efficacy of these interventions.
Well, it certainly does seem like there's a lot of uncertainty going on right now, but cancer care and taking care of cancer patients seems to be something that everyone can rally around. The next part of the report focuses on oncology practice and workplace trends, using something called the annual ASCO Oncology Practice Census. So can you tell me a little bit about that and talk about if there are any trends in the oncology workforce and workplace that are standing out to you as particularly important or concerning?
Well, that's a great question. As you know, the census was sent out and ASCO had collected information about practice setting, size, workforce, and patient volume from 1,500 practice sites across the country that represents approximately 8,400 oncologists serving at least 1.1 million new cancer patients in 2016. And the reason why this census is done is that, as you are aware, we are in an unprecedented era of healthcare reform. And oncology practices are having to adapt very swiftly in a changing landscape, while in addition to managing the persistent practice pressures, including administrative, economic, technological, and staffing constraints. So what struck me from this last census report is that oncology practices are still being strained under increasing practice expenses. We have seen the same result in past reports. But the majority of practices, in fact, 54% from this trend survey, identified increasing practice and facility expenses as a very top pressure. And that includes things such as staffing and equipment and overhead, rent and administrative expenses. And it was considered the most frequently cited concern for 2016. And above and beyond that, there is great concern about administrative burden on U.S. practices, no matter what the subspecialty is, and that includes oncologists. There actually was a study that was done that attributed that 49% of the physician time is dedicated to electronic health record documentation and desk work versus 27% to patient care. And another study that demonstrated that there was over $15 billion spent across 1,000 medical practices just for quality reporting. So this is a significant concern because what this administrative burden is doing is that it's reducing the amount of time that a physician has to spend with the patient in any given day. Well, then you put on top of that another trend that it was signaled and greatly concerns me, is that amongst the 12,000 or more hematologists and medical oncologists, there is indicators that 1 in 5 oncologists are nearing retirement at the age of 64 or older. So there's great concern about the shortage and upcoming shortage of oncology providers in the future. But in addition, what this trend noted is that the oncologists are unevenly distributed across the country. So one of the great concerns are those individuals, those patients that are in the rural areas where 19% of Americans reside, but only 6% of oncologists practice in a rural area. And in fact, what this trend revealed is that there were a number of states with sizable rural populations that absolutely have no oncologists with rural practice locations. So this is a real signal about access to care as well. And finally, there was some trends looking at perhaps the evolving role of cancer care providers. And certainly, that evolving role may actually be part of the answer to these challenges that I just identified.
Well, that's certainly a little bit frightening to think about the aging of the population. Some of the data here that the younger people moving into the field don't seem to be coming in at a rate high enough to replace those who might be retiring. But there are some nice suggestions for ways that we might help deal with this. One of them you mentioned is the evolving roles of providers such as advanced practice practitioners. So could you go into that a little bit?
Yeah, certainly. So actually, many folks have been working on refining the cancer care team so it can help alleviate some of the pressures that we just identified. And in fact, these broad changes in the areas of payment reform and health information technology and team science really have the potential to ease these burdens, as I mentioned, and offer increased time for patient care. And in fact, ASCO and the National Cancer Institute held a workshop in 2016 to assemble cancer care teams and try to apply these team principles to various case examples. And the good news is that there were a wide array of findings that was published in the November 2016 Journal of Oncology Practice. But in addition to that, recommendations include that there should be both public and private payer recognition and support of provider and patient communities to ensure that the policies that they're asking us to follow provide sufficient resources and infrastructure to support the novel approaches to care delivery across the healthcare teams and the care delivery settings. In addition, administrative requirements should be addressed because, of course, as we just mentioned, it does represent a growing burden and expense on practices. So the recommendation is that Congress, the administration, payers, and insurers should try to streamline these requirements so that oncology professionals can focus their time and resources on patients. In addition, there needs to be the continued implementation in a speedy way of the 21st Century Cures Act to address the issues of interoperability and information blocking, which often makes our day longer and complicates our day. Additionally, there's a request that Congress address the pre-authorization and payer requirement, as well as streamline any quality reporting that's required of us, while at the same time exploring the more appropriate use of clinical pathways.
I think those are all excellent recommendations. It has never made sense to me that we spend more time documenting and doing paperwork than we do actually seeing and taking care of our patients. I think anyone who hears that can't possibly make sense. So that actually makes a very nice segue into the next section in the report, which focuses on the delivery of high-quality value-based care and attempts at payment reform, and specifically talking about MACRA. So how is the move towards getting away from fee-for-service and more towards value-based care, how is this going to affect oncology care going forward? And what are some of the challenges we're going to see with these new models?
Yeah, so that's a great question. So as you're aware, MACRA was signed into statute to repeal the SGR, which we were all very grateful for. But the product of the MACRA was, in fact, the QPP, which is the Quality Payment Program. And what that program does is it creates a performance-based payment system for us as providers to be able to prove quality at the same time, prove stewardship of cost and resource utilization. But that said, to your point of your question, the QPP actually offers two pathways for Medicare payment, the first being the merit-based incentive payment system called MIPS, which actually retains the fee-for-service payment while consolidating the current existing Medicare quality programs that we report on, such as PQRS and the meaningful use, and the value-based modifier, which is determined by CMS. Then there's the second pathway, which is the alternative payment model, referred to as APMs, which is not fee-for-service, as you mentioned, but offers lump payments and financial incentives. What's important to understand, at least today, is that most providers, including oncologists, are going to fall under the MIPS, or the Merit-Based Incentive Program system, as opposed to the APM. Currently, the only APM that's available for oncology, or that's oncology specific, is the Oncology Care Model, which is a multi-payer APM demonstration project for delivering high-quality, value-based coordinated care. The problem is that this is a demonstration project, so there's only 196 practices that are participating, which means the rest of us who are not participating have to follow the MIPS track. So what I see going forward is that, at least initially, most of us will be reporting under MIPS, and those participating in the OCM will continue under that demonstration. But there was a patient-centered oncology payment model that was developed by ASCO. We refer to it as PCOP. Now, that's a model that has been proposed as a potential APM that's oncology specific for CMS. So that being said, the challenges to implementing MACRA are many. And one of the biggest challenges is, despite the fact that ASCO and other professional societies and organizations and CMS have been talking about MACRA for quite some time now, well over a year, many physicians are unaware of these reforms and are actually unprepared to make the changes to their practice in order to meet those requirements. So that said, there's also concern about specifically the movement away from fee-for-service into the new payment models called APMs. And ideally, believe, and CMS has stated that eventually they want providers mostly to be paid and judged by quality and cost resource utilization under the APM model. But as I mentioned, there's only a limited number of those APMs available for oncologists. So in the meanwhile, what the great concerns is a period of financial risk and uncertainty that MACRA rules may have for providers. And specifically, what I'm referring to is the resource utilization, the cost portion of the MIPS score. Currently, for 2017, the cost is not included in the MIPS score. And that was actually a compromise that CMS had made based on comments that were submitted by many, including ASCO. So we were very happy about that. But the problem is, or the issue is that it will start in 2018. Now, if you step back and you think about it a little bit, if we are to deliver high quality care, which means giving the right drug to the right person at the right time, that means that we're often recommending very expensive medications, the price of which that you and I cannot control. So on the one hand, we're going to be judged as to whether or not we're delivering quality of care, and that reporting will be available for CMS, and the public to see. But on the other hand, we potentially are going to be penalized because we're using the right drug and the cost is going to be so high. So the question becomes, is when oncologists are having their composite scores calculated, and now they compare us against other disciplines that are much less costly, where are we going to fall in that penalty and reward? And there's great concern that we are going to be at financial risk just for doing the right thing for our patients.
Wow, that's surprising that such an important law and such an important program is coming out, and it seems like much of the country is woefully unprepared for it. So I'm glad that at least ASCO has this in its sights and is trying to help the workforce and drive policy to at least move us in a direction where we'll be more prepared for it. Now, regardless of the payment aspects of things, I think everyone agrees that moving towards a more value-based care is the way to go. And obviously, ASCO has a big investment in developing value-based initiatives. Can you talk a little bit about that?
Yeah, sure. So I mentioned just a couple minutes ago that ASCO has developed an oncology-specific alternative payment model, or APM. It was actually developed by oncologists for oncologists, and it's called the Patient-Centered Oncology Payment Model, or PCOP. So currently, the PCOP is now being tweaked, and there are several subcommittees that are working with the Clinical Affairs Department to get the PCOP to a point where it can submit it to something called the PTAC, which is a review committee that will hopefully recommend this particular model to the CMS to be validated as an APM for oncology providers. But above and beyond that, COPI is certainly something that I think most ASCO members are very familiar with, and that's a quality oncology program initiative that was started years ago to help practices measure themselves against others to make sure they're delivering high-quality care. Well, the great news is that if you are registered in COPI for 2017, you can actually use COPI to assure that you can comply with the one measurement submission, which is part of the Pick Your Pace type of MIPS reporting for 2017. And even more exciting is that currently the Clinical Affairs Department under Steve Grubbs is trying to develop COPI to serve as a qualified registry to the point that in 2018, they hope to be able to report the required 60% of patients' quality measurements through the COPI system, as well as to be able to bundle that with other reporting, including advanced care information and the improvement activities requirement that's part of the MIPS score. So ASCO has dedicated a lot of resources to be able to embellish the wonderful COPI that we already have, to be a QCDR, to be able to accommodate the requirements of CMS, especially for 2018 and going forward, but also for 2017. In addition, ASCO has conducted a number of webinars and has a MACRA task force as well as trainers who are more than happy to come to practices upon request or to meetings to talk about MACRA. And in fact, ASCO's website, if you go to asco.org/MACRA, has a lot of information that's extremely helpful. And finally, the Clinical Affairs Department of ASCO, which was developed a couple of years ago, is dedicated to try to help practices be able to navigate the changing landscape. And they now have available a practice consulting service that can help practices in this transformation.
Oh, that's wonderful. So hopefully that message will get out that that's available. So to cover the last section on the report here, this focused on the development of learning healthcare systems in oncology. And I know that this is something that ASCO has been out ahead of with the CancerLink project. We had Bob Miller on for a podcast late last year to talk about how that was going at that point. So why are learning healthcare systems an important initiative, and how is this going to be impacting oncology care going forward?
Well, certainly I think most members listening to this podcast appreciate, the value of learning healthcare systems, being able to learn continuously by collecting the data that's not obtained from clinical research trials. As I mentioned earlier, we really are looking for learning healthcare systems to be able to help bridge that evidence gap that we certainly currently have with regards to what we're seeing in clinical trials, but what's actually happening to our patients in terms of quality of life and outcomes in the daily practice of individuals who might not have been able to qualify for clinical trials had they been open at the time. So we hope to be able to gain, by analyzing data both retrospectively and prospectively, evidence and new insights into clinical care and research. So this is especially important because, as we all appreciate, with all these rapid advances with regards to new therapies, the understanding of cancer biology and new testing, that it's becoming very complex, to treat patients, especially as we try to move more towards a personalized care system. So it's actually quite difficult for a general oncologist who's seeing basically many different types of cancer and hematologic issues on a daily basis to try to stay current with the evidence that's necessary in order to deliver the high quality care. And certainly, with that being said, the learning healthcare system is one way to be able to have us learn from each other and how we care for our patients, and then turn that into a point of decision-making recommendation for how we can care for the patient sitting in front of us. And certainly, there are already examples of learning healthcare systems in action. For example, the VA, is included in those initiatives, along with Kaiser Permanente in California and the California Department of Public Health. And they're actually beginning to show us examples of how both the public and private systems can use the aggregate data to improve the quality of care and care delivery within their own system. So that's signaling potential for expansion to much larger patient populations. As you had mentioned, CancerLink, of course, is the ASCO National Learning Healthcare System in Oncology. And that's currently gathering data from the EHRs and practice management systems of participating practices, of which there are now many, with the primary goals of being able to help us as oncologists help make better informed decisions clinically, as well as providing quality improvement analytics. Now, certainly there are challenges, as we talked about a little bit earlier, for learning healthcare systems, and it has to do mostly with the barriers to data sharing, such as intentional information blocking and the maintenance of what they term as data silos, which are created by incompatible EHR systems, as well as the minimal collection of patient-reported data that's due to partly patient privacy and security concerns, and then that burden that the collection places on oncology practices. And the good news is that the 21st Century Cures Act does in fact have provisions to ensure that our EHR systems are interoperable and support the development of learning healthcare systems.
I'm not aware that there's anything else like this that exists. So I think this is a wonderful tool, a wonderful report. Obviously takes a great deal of effort to put together. Thank you so much for joining me to go through this.
Great. My pleasure. And thank you so much for asking me to share my insights into the State of Oncology Cancer Care Report.
And I also want to thank all of our listeners out there who joined us for this podcast. The full text of the State of Cancer Care in America for 2017 is available at ascopubs.org/journal/JOP, published online March 22nd, 2017. Don't forget you can read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journal's mobile app available in the iTunes Store and Google Play. This is Dr. Nate Pinnell for the Journal of Oncology Practice, signing off.